So welcome, Hazel. Welcome to The Nutshell. Are you able to just kick off and tell us a bit about your professional journey to becoming a plant-based dietitian?
Yeah, and thank you for welcoming me to the podcast. It's nice to meet you both. I am plant-based myself, so that started my interest in the area, but originally it started from a nutritionist point of view, and I didn't necessarily know the medical aspects of the benefits of a plant-based diet. And I think as I've gone along over the past 10 years of being plant-based, more and more has come to light. So I qualified as a dietitian probably 5 years ago, I think now, from King's College London. And initially I went straight into research at King's as well in inflammatory bowel disease, which was really interesting because the first thing we were doing was a study comparing what kind of diets this inflammatory condition is having, in the sense of going through their food frequency questionnaires and food diaries and seeing how many of them had plants in their diet and whether they had almost a biased view. Then I went on to my clinical journey because it was really important to me to try and have a clinical and a research kind of background. And in my clinical journey, I noticed it was heavily leaned on having meat in your diet and dairy in your diet. And it wasn't really explored whether plant-based was an option or whether it was better. And then you get more specialized in the gastro world, which is my area of interest. And I find that people naturally, well-meaning health professionals naturally kind of advise people to cut out important fibers to help with symptoms. And occasionally I'd have some vegan patients come to me and they'd feel really disheartened because of a bit of bias, whether it was conscious bias or unconscious bias, but a bit of bias towards their diet and their symptoms and what was happening. But they didn't feel necessarily like they got good dietary support, even from other dietitians. So the longer I'm in the profession, I realize there's a gap in knowledge here. Even other dietitians who theoretically are nutritional experts, they're the most qualified. Some of them have a lack of understanding, and I guess it comes down to a personal interest. And as you know, there's a lot of bias online, a lot of misinformation. So eventually I decided, well, do you know what? I'm going to be part of, a movement in combating this and actually being do you know what? Soy is good for you. It's not what the milk industry is saying and going to cause X, Y, Z. And I thought I'd start getting involved in supporting that kind of niche group in gut health, but also the plant-based diet, because often people with gut conditions don't think they can be plant-based because they've been advised by well-meaning people to reduce those plant-based foods. Anyway, so it's quite a niche, but I wanted to be part of that. And then the longer I've been in it, I've met all these communities that I didn't even know existed, like the plant-based health professionals or the podcasts. And it's been really nice to learn about it. So that's kind of been my journey. And yeah.
You mentioned there that when you were at King's, it sounded like you were doing something on inflammatory bowel disease. But is there a point at which you moved away from that and specialised in irritable bowel syndrome, IBS?
So I do both. So in King's, I was primarily doing research in inflammatory bowel disease. And then I went on to do my clinical training, clinical practice, and I specialised in gastro. And within the NHS, you don't just get to do one set condition. You do all of the gastroenterology conditions. So then the longer I did, and numerous ones like IBS, celiac, IBD, your specialism, your interest gets a bit more defined. I still really enjoy inflammatory bowel disease in the sense of I think it's got a lot of grey areas that need answering. And that's also why I like IBS, because it's also got a lot of grey areas that need answering. It's not as straight cut as one would think. So yeah, I am exploring more and more research in IBS, but I still like both areas, and I'd still class them both as my favourite specialisms, but encompassing the plant-based element as well.
So, when we were coming up with questions to ask you for this podcast episode, we were thinking, we'd really like to focus on irritable bowel syndrome. But even in trying to come up with those questions, it's impossible not to consider some of the other areas, because obviously those are the conditions that are often having to be excluded. Maybe we could ask you as a start to give us a sort of brief overview of IBS, what it is, and what symptoms are commonly seen in that condition, irritable bowel syndrome.
Yeah, of course. So irritable bowel syndrome, as it stands, the understanding of it is that it's a collection of symptoms without necessarily an organic cause. And what I mean by an organic cause is a level of inflammation or gastric ulcers. It's a collection of symptoms within the gut that are very real, but they don't necessarily have a cause per se. Some hypotheses of the condition is that it's visceral hypersensitivity. So hypersensitivity within the gut lining that is causing the symptoms. Comparison studies between those that don't have IBS and those that do have IBS, they'll put them on a similar diet and the digestion process will be the same. So they'll both digest the food and produce gas and pull in water. But the difference between the two cohorts is that the IBS population can feel what is happening and they have a reaction to what happens and they have pain. So one of the diagnostic criteria, the Rome criteria, is that they have to have pain and altered bowel habits related to it. There's now more diagnoses for things like functional bloating where you wouldn't have pain or altered bowel habits sort of thing. So IBS has to have pain and altered bowel habits, but the understanding of it is that it's visceral hypersensitivity. And this can be modulated by a number of things. It doesn't necessarily need to be diet. Obviously, diet plays a big role because that's what's influencing your gut's microbiome, your bacterium. But it's also can be influenced very much by the gut-brain axis, which I think we'll talk about in a bit more detail later, but your lifestyle as well. So there's a number of things that can kind of impact IBS, but that's our current understanding of the condition.
When I was I don't remember if it was medical school or when I was training as a GP, but we used to talk about IBS-D, which was the diarrhea type, and IBS-C, which was constipation, and a mixed where people get both diarrhea and constipation as part of the change in bowel habit that you see with IBS. Is that still relevant?
Yeah, that definition is very much still relevant and helps lead your treatment of the area. So there has been some conversation as to whether IBS-D and IBS-C just need to be separated full stop as two very different conditions because the treatment options from dietary to medication are very different. It still very much stands. I think the confusion sometimes gets when you've got more of a mixed habit because it's figuring out, does it lie more on the constipation and overflow diarrhea point of view? And what is the influence of the mixed habits if there are very clear mixed habits? Defining the IBS is very helpful for the treatment going forward.
When you think about constipation, sometimes I've thought, well, how is that different to IBS with constipation? Because constipation is almost always painful, and we know that we've got categories of people that suffer from that. And so often we can just find an underlying cause, which would be just not eating enough fruit and vegetables. Are you able to separate out constipation per se, just functional constipation from IBS, or am I mixing up two things here?
No, I think you're right. I think it is very difficult to figure out which is functional constipation and which is IBS constipation. I think it circles back to the pain element because some people with chronic functional constipation don't necessarily have pain. And then there is the bloating element as well. So for the IBS population, they suffer more with bloating, and functional constipation can also have it as well because they're very backed up, but it might not have the same reaction to those with IBS. And it can be really difficult to define. And I think one of the things dietitians struggle with is figuring out whether it is a transit issue in the sense, is the muscles of the gut slower, or is it a food and a lifestyle issue? Because the mechanism makes a difference to the treatment. So we can optimize the diet as much as possible for someone with constipation, say, but if the motility is an issue, it still might not make a difference. And if you're adding in constipation foods that maybe bulk it, it could even worsen the issue if the motility isn't working. So it's a really difficult area. But I think ultimately we try and stay within that definition of, do they have pain and do they have other IBS symptoms as well? Because if they do, regardless of whether there's functional constipation at play, we also need to treat that. For example, if I saw someone with what I considered IBS-C, I would obviously try and optimize their motility, but I might try and also consider what foods would be helpful to aid with that bloating whilst we're optimizing their motility. Whereas if they just had constipation in the sense that they went once a week, but they didn't really have bloating or pain, then we'd just be trying to optimize that stool habits and not so much worry about adding in constipation foods that might worsen bloating, because that's not something they suffer with. So it's difficult to define, I think, as well.
It is. And it's also difficult to diagnose, isn't it? Because this is what Daisy and I were talking about, when we were preparing for this. And so, Daisy, you've got some questions about why you're so reluctant to diagnose IBS.
Yeah, I've always been taught that IBS is a diagnosis of exclusion. As GPs, we all do. Obviously, we need to exclude anything more sinister first, and the stool test for culture, perhaps even a fit test to look at hidden blood, or a blood test to look for celiac disease or other conditions. Do we need to think of breath tests or lactose intolerance? And I feel really reluctant putting an IBS label on someone who I haven't talked about the possibility of a lactose intolerance, for example. Would it be reasonable to suggest they try a lactose-free diet for 2 weeks and see whether that affects the symptoms?
No, I think it's good that GPs try and be thorough before they send to dietitians, especially NHS dietitians, because as you can imagine, they're very stretched. It would be months potentially until the patient would see a dietitian through the NHS. But yeah, the celiac screen, the inflammatory screen, the fit screen, they're all kind of the things we'd expect to be done beforehand, because I think the working theory is that it is still a diagnosis through exclusion. When they've compared the Rome 4 criteria to the likelihood of conditions, IBS-C and IBS-M tend to always be IBS. Whereas with IBS-D, it could be other things. It could be IBD, it could be microscopic colitis, it could be bile acid malabsorption. The lactose point of view, I think it's a good point to bring up, because I know it can be up to 70% of the population are lactose intolerant, but this really depends on the group that you're focusing on. So when they've done studies in the IBS population, it's as varied as 5 to 90% might have lactose intolerance. So in other words, we don't know, but it doesn't hurt to check. One of the issues that we could come across from a GP point of view is obviously you're quite time limited. So sometimes asking people to cut things out of diets, that can leave them with more questions than answers. Most people might know, well, if I cut out dairy, I'll just replace it with a milk alternative. But other people don't necessarily have that answer for themselves. They just cut out the dairy and don't replace it. So then they might get deficient. And then another person they speak to might be like, oh, it's definitely gluten. So they'll cut that out as well. So I've met people on very restrictive diets that haven't necessarily had dietary support. So that can be the challenge with advising people to cut out foods, because I understand, it definitely helps, but I think not everyone. Some people are really good at, looking things up, but some people, it can just become quite an exclusive diet. So when I see them, it's very much supporting them to get things back in their diet and not be malnourished, because they got so averse to lots of foods. So I think if I saw them, I too would consider the lactose thing, especially if I was seeing a lot of lactose in their diet, and especially the more bloating, diarrhea, prominent symptoms. But the difference, I guess, between a GP practice, and I'm not saying yourself, but I mean, like what I've seen in practice is I'm at least then going to go through what your alternatives are and make sure they know exactly what they need to have, and that it is only for 2 weeks. And then we will touch base. It can be challenging because I do think it has a place, but the support needs to be there.
Yeah, that makes sense. And like Claire said, we've spoken before, I feel quite uncomfortable with chronic diarrhea and just labeling that as IBS.
Yeah.
And so I will often refer actually to a gastroenterologist, a specialist, to look at bile acid malabsorption. Is there a place for those sorts of tests or breath tests and that sort of thing in your practice?
So generally what I've seen is past the age of 40, especially in women, they will do things like a CCAP for bile acid malabsorption and microscopic colitis, colonoscopy with biopsies. So that will be looked into by a gastroenterologist past a certain age. And sometimes in younger ages as well. It's obviously symptom dependent. But I think it is good practice as a GP to refer on to a gastroenterologist, because they obviously are more niche. They see it all the time and they should be able to put them in the right direction. When it comes to breath tests for small bacterial overgrowth, small intestinal bacterial overgrowth. That condition is very much disputed in the gastroenterology world. My understanding of it is that it has got very popular on social media, but it's not necessarily a consensus in the gastro world. And when they've done big studies, they've said that we shouldn't be routinely offering these breath tests because they don't actually diagnose intestinal overgrowth. They diagnose your transit time in the gut. So it doesn't actually give you a definitive, you have this condition. And then the treatment for this condition, which is disputed, is antibiotics and a certain antibiotic. And we know when we've done studies with just an IBS cohort that if you put them on antibiotics for a while, things get better, but then they get worse again. So with SIBO patients, we often see they get put on antibiotics, things get better, and then they get worse again. So is it just IBS that you're putting on antibiotics and things are getting better? I think ultimately we don't know. From a dietary point of view, the treatment people tend to work at is like a modified low FODMAP, which again is an IBS treatment, and probiotics to optimize their gut health when they're on an antibiotic, which again is just like standard kind of dietary treatment because you're on an antibiotic, it's going to affect the gut microflora. So there isn't necessarily any specialist SIBO dietary advice that I'm aware of. But I think my cautious thing with the breath test is you may be unnecessarily putting people on antibiotics again and again, which ultimately is just going to worsen the picture. And our diagnostic criteria for that is not accurate as it stands. That's not to say the condition isn't there. And I think, you know, for things like inflammatory bowel disease or where they've had bowel surgery, definitely there has been some evidence that that can happen. But for somebody who hasn't had bowel surgery or inflammatory bowel disease, it is very much questioned. And our tests aren't necessarily diagnosing it. So I'm always a little bit skeptical, and I just try and treat their symptoms as I see them. But I will also talk them through that. And if they ask for any documentation, I'm always happy to share as well. So I always want to be as open with the patient as possible.
Yeah, thank you for clarifying that. That's really fascinating, isn't it? We've had many of these discussions, Claire and I. But say you ultimately have a patient who has been referred to you with now a working diagnosis, having gone through the appropriate tests and excluded other conditions. Should we move on to diet and treatment options?
Yeah, so you've already mentioned the FODMAP diet, and I think this is a term that is just becoming familiar to lots of people now. Is this still current? Is this still something that you're using? And if it is, what is it? What does it mean for a patient to go on a FODMAP diet?
It is still very current. It is still the most effective dietary treatment for IBS patients. However, it is the most effective dietary treatment for specific IBS patients. So not all. It's not a one-size-fits-all dietary treatment. And I think that's sometimes the confusion over the FODMAP diet. So what the FODMAP diet is it's excluding for a short period fermentable carbohydrates. So FODMAP is fermentable oligosaccharides, monosaccharides, disaccharides, and polyols. Sorry, I did that the wrong way around, but yeah, that's all the words. But it's fermentable carbohydrates. And what these fermentable carbohydrates do is essentially in everyone, not just the IBS population, they go through to the small intestine. And for some of them, we don't necessarily have the enzymes to break up these carbohydrates fully, which is normal and often a good thing. And then it goes through to our large intestine and they ferment. So they produce fatty acids, which have a positive influence on the gut for the most part. And they ferment, so they produce gas and these fatty acids, and they pull in water. And for people in the IBS community where they're struggling with bloating and diarrhea, what this does is it can sometimes cause more of a diarrhea reaction or a bloating reaction with visible distension. And that pressure in that area as well then pushes on your nerve receptors and causes pain. Whereas these FODMAPs do exactly the same effect in someone without IBS, but it doesn't make a difference. What we do in the FODMAP diet, only for this subset of IBS, is we would exclude the FODMAPs for normally 6 to 8 weeks. If your symptoms are then markedly reduced or stopped, you know that it's the FODMAPs that are playing a part in your IBS symptoms. But like I said, these FODMAPs are really important for our gut health in general. So we know they encourage the good gut bacteria. They're often really important for making sure your bowel is moving effectively. So we have to reintroduce them back into the diet. There's no long-term studies of people being on the FODMAP diet long-term, but in the short studies they have of the FODMAP diet, we know it alters our gut bacteria. So it reduces some of the good gut bacteria. It's integral to pop these foods back in your diet, but we need to figure out what your individual levels of tolerance are. So you'd stay on the FODMAP diet during the reintroduction process, and you'd pick maybe your favorite thing that you've missed the most, like bread. And you'd do a small bit of bread on day 1 and check your symptoms. If you tolerated that fine, you'd do a little bit more bread on day 2 and check your symptoms. And if that's fine, you do a full piece of bread on day 3. And if you're symptom free, you know you can have bread in your diet. Then you take bread back out, go straight back on the FODMAP diet, and pick another food and find out your tolerance levels. So garlic, you might find you can only have a quarter of a clove before you get symptoms. And then you have to make sure you're symptom free and on the FODMAP diet every time you reintroduce these foods in. Once you've gone through all the foods, which can take another 10 weeks, then you've got your personalized levels. So we put them all back in your diet and we figure out what your personalized FODMAP tolerance level with them all back in your diet is. So people might be absolutely fine with their FODMAP fruits and vegetables, but bread they can only maybe tolerate every other day. It's figuring out that together and making sure your IBS symptoms are manageable with those foods within your diet. Yeah, so that's the kind of rundown of the diet. So it is very much a very effective diet, but it is lengthy. And there's a lot of things you can do with your diet prior to trialing the FODMAP diet. So generally, we do that as not a last resort, but we try simpler options first that don't impact your life so much. There's also a lot of speculation about whether we should be doing a FODMAP light approach rather than the full FODMAP diet. So essentially working our way up. So we now know with the research we've got that there are certain FODMAPs that impact people more than others. So the theory of the FODMAP light is to exclude those ones first, because it's a much smaller subset of foods. And if your symptoms are better after just that small subset of foods, then you don't need to do the full diet and you just do the reintroduction with the small set. So that's less impactful on someone's quality of life and not as lengthy. And then other people in IBS debates have discussed whether we need to be more personalised and this is the FODMAP you're having a lot of. Just that one, let's cut that one out. Ultimately, you take your patient case as it stands. And if you know that someone's quite food averse, the FODMAP diet may be a bit much for them and worsen their anxiety and relationship with food. So then you might think, okay, well, I can see you're having a lot of lactose in your diet. That's a FODMAP. Let's just cut that out for a period. And if things get better, then we know it's that might be your main trigger. So it's working with the patient, but I think understanding the FODMAP diet is really key to working with IBS.
That does sound really hard. And I think that emphasises why if a patient says to me, should I try the FODMAP diet? I always say, well, not without a dietitian, because it's so difficult, isn't it? Obviously, we know that plant-based eaters are going to be eating a lot of these FODMAPs. Do you think that if they go and see a dietitian, that a dietitian is going to be able to work with them effectively on the FODMAP diet if they're not, specialising in plant-based eating?
Yeah, I think it's definitely possible to do vegan FODMAP diet. It takes a bit more work than if you're an omnivore, in the sense that you're probably going to have to do a bit more cooking, but it's completely possible. I myself, like I said, I'm plant-based, I'm vegan, and as part of the FODMAP training, when you do it, you have to do a period of the FODMAP diet to see what your patients go through. So I have done a vegan FODMAP diet, and like I said, it's very hard, I'm not going to lie, but it is possible. I'm more inclined, I think, to give the option to the patient of whether they want to do the full FODMAP or the FODMAP light, depending on what I'm seeing. Some people want to do the full FODMAP because they want to be absolutely sure, but then it's just coaching them through the fact that it can be hard. I think the hardest point isn't so much the fruits and vegetables. I mean, bread was hard for me personally, but it's your protein source. So our main protein source in a plant-based diet is your legumes, but alternative low FODMAP protein sources on a plant-based diet are things like myoprotein, so corn, but also tofu, certain nuts and seeds. So you can still get your protein needs, but it requires more planning. There's also the latest King's College London FODMAP booklets, which are our main source of guidance, have now got a section for those following a plant-based diet, in the sense that they've got a yellow section. So normally green is what you can eat, red is what you cut out. They've got a yellow section, which is what you can have in moderate amounts for those that maybe rely on these foods. So you might be able to have 2 tablespoons of kidney beans, for example, alongside your tofu, to make sure that you're getting what you need. And that is kind of you can only have them in moderate amounts. So it's not quite low FODMAP, you're a bit more FODMAP, but it's just working within your limitations. But ultimately what we're trying to do is reduce those high FODMAP foods to reduce the response. So that is still reducing the FODMAPs. It's just a bit more difficult, basically. That was a long answer for it's a bit more difficult, but possible.
No, that's brilliant. And it's really encouraging as well. I think sort of coming back here, we're thinking more about coming back to something about the cause of IBS and whether we're seeing more of it as a result of Western diets and maybe something that's happened to our microbiomes in general. Is there any evidence that we see more IBS in people that are not eating fibre-rich diets?
Yeah. And, there is the whole chicken and the egg argument when it comes to IBS. So IBS populations do tend to have less of a healthy eating pattern, in the sense that they have more restrictive eating patterns. There has been some evidence to show that they rely more on processed foods. But then the argument is their IBS due to that eating pattern, or is that pattern due to the symptoms they were experiencing? And this is where the categorization of the IBS can be helpful. So, for example, if they're more IBS-C, it could be due to a lack of, regular plant-based foods. But yeah, I think sometimes it definitely does play a part, and there is the chicken and the egg argument. But ultimately, this is seen worldwide on numerous diets. So it isn't just the Western diet that is suffering with it. And I think you have to take it an individual case-by-case scenario. But we do know that obviously ultra-processed foods do make a difference to our gut. So there will be that subset of people that if you're introducing more fibre into their diet, they will get better, but not for everyone.
So just on that note, Hazel, and the gut microbiome, we hear a lot about the importance of the microbiome for our health. Is there any evidence to support the use of probiotics? For example, I've heard about people looking at a probiotic protocol to sort of revitalize the microbiome before introducing certain vegetables or higher FODMAP foods.
I think with the probiotics, it's still a really difficult area. And this is because there's so many strains on the market, but there's not necessarily enough studies on each individual strain or each strain combination to make a consensus on every single thing that's on the market, if you know what I mean. There are definitely times where, for example, in IBS, the British Dietetic Association created a consensus guideline of certain strains that have been shown to be effective with certain symptoms such as bloating, pain. But again, it's whether that strain is found in the UK or what kind of effect it is on the microbiome. When it comes to optimizing the microbiome before adding in fruits and vegetables, I'm not so sure. It's not going to hurt, but I think I'd still want to gradually reintroduce those veg back into your diet, because your gut bacteria being optimized, I'm not sure how much that would still make a difference to how much of an impact having veg all at once. It would still shock the system, in my mind. If you've had a period of not having these foods, then I often describe the gut as a simple creature, in the sense that it is a muscle and it needs training. So if you wanted to do a marathon, well, for me, if I wanted to do a marathon, I couldn't just run the marathon tomorrow. I need to get my body used to it. And if you've had a period of not having fibre in your diet, same kind of thing. If you do all that fibre, you go 0 to 60, you are going to have symptoms. And I see this quite regularly with people like, I can't tolerate beans. But what they'll do is they'll not have beans, have a massive 5-bean chili, and then have loads of symptoms and say, I can't have beans. But what you need to do is get your gut used to having a little amount of beans and work your way up, which is kind of similar to the FODMAP thing. It's finding your tolerance, but also getting your gut used to it. But the probiotic conversation, just to circle back, I think the problem is the evidence is very wishy-washy and it's not very defined at the moment. But there are places for probiotics in the sense that it's worth trying. But we always advise try it for 4 weeks. If it makes a difference, great. But bear in mind that might be an ongoing cost. And probiotics can be quite expensive. For example, Simprove is one of the more expensive ones on the market, but one of the more popular. So it is an ongoing cost burden. But if they don't see a difference, just stop. So I'm always a bit more keen to optimize their gut bacteria naturally through a healthy diet and lifestyle rather than give everybody a million probiotics to try, which might not be effective, but I know diet and lifestyle is. Yeah, it's personal practice ultimately, but I think the evidence isn't strong enough for me always to say this is definitely going to help because we just don't know fully yet.
Yeah, that's useful to know. And I love that analogy of the marathon and getting your body used to a certain way of eating or exercising. And so if people are going to be reintroducing food slowly and gradually to get their microbiome used to it again, have you got any tips or tricks? Do you ever give any hints to people how to reduce that bloating or gas they might experience? Typically, I suppose it's with beans, isn't it? Or certain cruciferous veg, I think.
But also, so it's your fructans as well from your FODMAP. So you've got your garlic, onion and wheat. They cause a lot of bloating as well. Again, not in everyone. So it's important to know what impacts you. But bloating's a funny one, it's not always the food. Sometimes it's simple as the dietary pattern. If you skip meals or have long periods without eating, that can often worsen bloating because we swallow gas while we're not eating. And then when we do eat, we have big portions. We swallow some more air. You're not stimulating your gut regularly, so the gas isn't moving effectively. But if I was going to get veg in someone's diet, you asked, is there a gradual approach? I think it would be looking at where they are and moving up slowly. So if I met someone that only had vegetables 2 times a week in the evening every day, but the rest of their diet was very lacking in fiber, then I'd say, okay, well, consistently, we're going to have veg every evening for the first week. And then I want you to think about what veg you can add into your lunch. And then after you got comfortable with that, maybe a week, we'll then add it into your breakfast. Once you're comfortable, get it really gradual. But the importance is I want them to work on which fiber they want, because it's not going to work if I say you have to have strawberries. They need to figure out which fiber works for them. And sometimes that's as simple as their likes and dislikes, but it's getting their body used to it, but also themselves. It's like with any kind of lifestyle change, it has to become habitual. That's how I would do it. But from a bloating point of view, I'd look at their lifestyle, their dietary pattern. And there are certain foods that I might ask them to modify, but there's also certain foods I'd ask them to add in. So for example, psyllium is a food that I might ask people to add in because that's been shown to help kind of encapsulate gas and release it more slowly. So it was done in combination with inulin, which is a particularly gassy fiber, and that was shown to still reduce the gas pressure. Obviously, it won't stop gas happening, but it just reduces how quickly it goes out. Okay, it depends on the person.
I've heard of psyllium husk. Is that what you mean?
Yeah.
Are we talking about like
psyllium
a powder?
Husk, yeah. The powder is normally better for getting the dose that you need. The capsules, it can get quite expensive. Yeah.
And on that note then, is there any role for medications whilst people are reintroducing these foods?
Yeah, I mean, I know some people that feel that diet and lifestyle is not effective and they need amitriptyline or an IBS medication to help going forward. Certain gastroenterologists I work with that have been in research for a number of years feel like there's 3 pathways you can go down for patients. So there's medication, there's diet, or there's lifestyle and psychological support. For some people, it's combined. For some people, it might just be that they need that medication whilst things calm down and whilst you get them in a good place. It's really individual. But it ultimately depends on the patient and how they think their symptoms are managing.
I was thinking along the line of peppermint oil capsules, which I think is my cop-out prescription when I've got nowhere to go in the consultation.
It absolutely isn't a cop-out. It's got loads of evidence, but I wouldn't necessarily class it as a medication either, because it's just peppermint oil.
Yeah,
Studies with that has been shown to relax the lining of the gut and therefore allow the gas to move more freely. So it's actually a really effective treatment that I often mentioning for people with bloating and pain. But when they're worried about popping pills, I say, but it's not a medication per se. You're just having peppermint oil.
Oh, that's good to know. I'll feel more confident when I suggest that next time. Because quite often people have tried over-the-counter. Buscopan is the classic one, isn't it? Most people have tried already. Is there much evidence that's helpful?
I've not got a pharmacy qualification, so it's very difficult to say specifically for drugs and dosage. I can only kind of work with what I see with my gastroenterologist. I know people do take a collection of medications. Buscopan, I have seen, and people often use it with good effect. But again, as things calm down, I find people do tend to rely on their medication less. But again, it depends on the patient.
Yeah, it's probably useful for a transition period rather than long term, isn't it? Brill. Okay, peppermint oil then. I'll remember that.
Right. So pivoting back, you mentioned there some people taking amitriptyline, which I associate as a medication that's used to treat stress and anxiety. So maybe this is a good point to come back to the gut-brain axis and what we know about the role of the brain communicating with the gut in terms of it affecting IBS symptoms.
With regards to the amitriptyline for IBS versus amitriptyline for stress and anxiety, the dose is very different. So it's a lower dose for IBS, which just has an antispasmodic effect, doesn't necessarily address the stress and anxiety that the dose required for that treatment. So that's an important definition, because that's often the discussion that patients have in my MDT clinic with the gastroenterologist. They're worried about taking something that modifies their moods, but the dose for IBS and amitriptyline is much lower, so it's not for mood management. But the gut-brain connection is a very real situation for IBS. We know that stress can trigger IBS. You know, if you have a particularly stressful period, that can set off IBS long term. So, for example, bereavement or domestic abuse, we know that these are triggers. Again, we're not fully clear as to why it is an ongoing IBS diagnosis afterwards. Have you disrupted your gut microbiota, or have you kind of activated a hypersensitivity that wasn't there before? I don't think it's particularly clear. You know, when I've been in talks or training for psychological support, there is an argument that we put in protective mechanisms for our IBS that then have like a biological reaction. So the example I give to patients is most people know that if they have a presentation or something, or a podcast interview, they might have some IBS symptoms because they're nervous. But what happens long term with IBS is you get symptoms in your tummy, and that because of your stress, but then your symptoms in your tummy make you more stressed, and then you get more symptoms in your tummy. And it's like a vicious cycle. And the gut and the brain are very much connected by the vagus nerve system, but also our immune system and our endocrine system. So that kind of vicious cycle can go on. It can take a long time for you to work on that brain connection to calm down the gut. So from a psychological support point of view, there have been studies that have compared the FODMAP diet to, for example, yoga, and it's been just as effective. Again, which one is it? And I think as clinicians, we work on the basis that it's probably a bit of both going on, because what you do, if it is a stress relationship, is people tend to put, like I said, protective mechanisms in place. So they'll be like, oh, well, I can't eat this food because that causes this symptom. And then they'll go to a restaurant and they'll accidentally have that food, and they'll definitely have the symptoms. Or another example is whenever they go out, they have to be near a toilet. And if they're not near a toilet, they're definitely going to have an accident. But if they're not near a toilet, their anxiety is going to worsen. And obviously their stomach's going to happen, and they're more likely to actually need it. So I know gut behavioral therapists really work on trying to alter those protective mechanisms to move away from those anxiety episodes that actually cause physiological reactions. but it can be a very convoluted thing to add into, your food modification as well, which is why when I was saying back to the FODMAP diet, it's really weighing up where that patient is in their relationship with food, because you do not want to add an additional anxiety onto them if you think that is their primary cause.
Got it. So it is possible then that a dietitian might talk to somebody about how to manage their stress. Is that part of what you do?
We can, on a very simple term. I'm not going to try and pretend I'm a therapist or somebody that specializes in that area, but if it's something that I'm seeing, then I can direct people in the right direction. So obviously, if it's on a simpler level, I can say, okay, well, what kind of things could you do for your gut-brain interaction? Could it be yoga, which we know has a lot of evidence? Or could it be mindfulness, such as using YouTube or Headspace or Calm to help things? There are certain apps now coming out that work on gut-based CBT or gut-based hypnotherapy. Nerve is one of the most known ones. So that might be something that you ask them to consider. But the longer I go on in my practice, especially from a private side, I'm now connecting with gut-based therapists in the sense of, if I feel that the patient is better placed with them, then I will refer them on. But it's knowing your limitations as well. So I think it's important for me to be able to have an understanding of that connection between the gut-brain connection, but also know when it's no longer my role, isn't necessarily their treatment anymore, and being confident and able to say, I think it would be better if you explore this route with this person, and just allow the patient to make that decision themselves. Because I've got a lot of patients that, although you'll talk that through with them, they absolutely don't really want to. They still want to focus on food, and that's okay. And maybe they're not finished with their food journey, but knowing your boundaries, I think, is important.
Hazel, you clearly know absolutely loads about IBS, and we touched on it earlier that all dietitians will be sort of trained in how to manage various gastric conditions. But in terms of people accessing a dietitian for IBS, are they available everywhere, or do you need basically a specially trained one?
A specially trained one is better. What you often get, unfortunately, due to, funding in the NHS, is you might get sent to a junior dietitian who only has a basic understanding of IBS. They can do what we would describe as the first line IBS treatment with patients well. So they'll go through their eating pattern, they'll check on their fibers, they'll make sure they're not having some of the more obvious foods, like, for example, if they're having bloating but lots of fizzy drinks, stuff like that. But when it comes to FODMAP trained dietitians, that's quite an expensive course to the IBS. So it's not that available. So if I look back to my own training, I had to really advocate for FODMAP training in one of my trusts, and it took longer than it should have done, but they still expected me to see IBS patients prior to that training, which means that if you're not trained in FODMAPs, you kind of giving them a disservice because you don't fully understand the mechanisms at place. A specialist is best, and the way you can access specialists through the NHS is usually through a gastroenterology team. So GP refer onto a gastroenterologist onto a gastrodietitian. Whereas if it's just done through the GP, sometimes it just goes to a community dietitian who you don't know whether they're FODMAP trained. Some of them are. Some of the better community trusts do, but not all. And I think that's the hard part. If you're accessing it privately, then you can go through the British Dietetic Association and you look for a FODMAP trained or a gastrodietitian on there. And most people wouldn't call themselves a gastrodietitian unless they've done FODMAP training. I can't speak for everyone, but in my personal experience, generally they're quite well trained and experienced in the area. So yeah, it can be hit and miss. That's why I think going for a gastrodietitian through the gastroenterology department is probably your safest bet. But it also doesn't hurt to check their qualifications, like, are you FODMAP trained? Because you can just answer, and then if they're not, you can always request someone that is.
I think if I had a problem with IBS as a plant-based person, I would want to consult with you, Hazel, because I've been really impressed by everything that you've told us so far. So if anybody listening is in that category, how could they consult with you?
So I do work privately. So I've got my own consultation business, which is hcdietetics.com. So you can find me through there, and you can book in a 15-minute chat, which is free, and we can talk through your issues and see whether I'm the best person to support you. You can also find me on the British Dietetic Association freelance dietitian directory, so I am on there, or through Plant-Based Health Professionals directory as well. From an NHS point of view, it's a bit harder. I'm at Liverpool Trust, so again, you'd need a referral through gastroenterologists to get to me, but privately, I'm a bit easier.
That's great. Well, we're coming to the end now, but we finish off, as I hope you've been pre-warned, with asking you what you'll be having for dinner tonight. And we love having dietitians on because they've always got great, lovely meal ideas. So don't let us down.
Oh God, I'm going to let you down. So I'm moving at the moment, so I'll be in Liverpool tonight exploring the eateries after moving, very tired. I can tell you what I had the other night. So I made a lovely chili. It wasn't a mixed 5-bean chili because I know my limitations with my beans. So it was a chili with some beetroots and some sweet potato. And I like to go on the seasonal veg, as well as having some kidney beans and some sweet corn in, with some brown rice and some avocado. So that was my meal last night. But tonight it'll probably be Thai food. I'm not going to lie.
Oh, that sounds lovely. And yeah, I mean, there's no limit for me and beans. So yeah, just something around that idea I would love to tuck into tonight. But Daisy, are you going to be making something similar?
No. Tonight, tonight I'm actually going to be having breakfast for dinner. We do this sometimes when we've got nothing left in the fridge, Hazel. I've literally got a pack of tofu, some vegetables. We're going to be doing our weekly shop tomorrow. So tonight I'm getting rid of what we've got. I'm going to have a scrambled tofu with some mushrooms on the side and some tempeh bacon, which is actually a recipe similar to what we made when we were on a Chef AJ live cook along a few months ago. So if you're really interested in this recipe, you could just watch our cook along live. But it's sort of 10 minutes and it's a clear out the fridge type of recipe. So whatever veg I've got, I'll chop up and pan fry that alongside scrambled tofu. And it's easy and quick. And it's delicious, isn't it, Claire? You've tried my scrambled tofu.
I'm just wondering, can I come round again? I might cancel because I know you're going to ask me what I'm having for dinner, but I'm going out. But I think that, an invite over to your place, Daisy, might persuade me to cancel the restaurant booking.
For breakfast, dinner. Do you know what you'll be having, though? Are you going to a nice
eatery? I think I'm going somewhere you've been as well. I'm going to 123 is it 123 vegan? So it'll probably be their vegan sushi, which I can make. And on another episode, maybe I'll talk about vegan sushi a bit, but it will be the really professional stuff with a lovely, really crispy sesame seeds on the outside. And they do kind of like, I'm not so bothered about this, but they do make a sort of mock fish as part of the sushi rolls and things.
How exciting. You've got to tell us
really
what
nice.
that was like.
Yeah.
Oh, well, look, Hazel, it's been really fantastic to have you on the podcast. You're, as Claire said, obviously so knowledgeable about the topic and we could have covered so much more. But thank you very much for your time and expertise and chatting with us.
That's okay. It's been really lovely meeting you both. Thank you very much.